for dinner?
Worms within.
Alright, good afternoon everyone. Thank you for coming to my presentation again. Today's topic and title is Worms Within, a Strongyloides case. Now before I go ahead, there's a lot of terms in here that are pretty complicated, like the word strongyloides, so if I destroy it, please forgive me. Now before we move on, and for those of you that are eating, I want to go ahead and show you a few pictures of worms. Strongyloides is not commonly known of or heard about. We usually hear about the hookworm. They're both similar parasites. They both attach to the intestinal lumen a little bit differently, so I'll go into that later on. Today's objectives, first of all, I'm going to introduce our patient. I'm going to describe the disease, the pathophysiology, the etiology, and how we treat it. I'm going to go ahead and summarize the treatment the patient received and discuss the outcome of this encounter. Our patient, the initial presentation, she showed up on day 1 to the ED. ZK, she was a 66-year-old Hispanic female. Showed up for abdominal pain with a twisting, constant, severe description of it. She also reported nausea, no vomiting, but increased oral intake, expiratory wheezing, and non-bloody stools, loose stools upon admission. She denied any recent travel, which is one of the things we usually think about with diarrhea, maybe traveler's diarrhea. And 1 month prior to her presentation, she had an acute exacerbation of her COPD. Her CT scan showed some gastric distension, and secondary to dehydration, she had acute renal failure. Her past medical history, as we can see, correlates to what she came for: COPD, asthma, type 2 diabetes, hypertension with no known drug allergies. Now our patient, upon initial presentation, she had some of her vital signs and her labs not correlating with the normal. As we can see here, her heart rate was slightly elevated at 100 beats per minute. Her blood pressure, despite her hypertensive disease state, was actually under goal, which, I don't think if it's a time to congratulate her or not, but she was under goal. Her white blood cells were actually elevated, very elevated, almost double the normal. Her platelets slightly elevated, although still within range, which was a good sign. The neutrophils elevated, monocytes and eosinophils also elevated, which are all signs of infection. As far as her medications, she was on her standard hypertension medications. I bolded the most pertinent medications, so for ease of view. Her Bio-K, of course, upon showing up with diarrhea and past exacerbation of her COPD, we might be thinking maybe as a result of her exacerbation, she was given antibiotics that could have caused her to get Clostridium difficile. Of course, we already asked her the question if she traveled or not, but regardless, as a standard protocol, we would be giving her ciprofloxacin and metronidazole for the treatment of diarrhea. Her Advair for her COPD or asthma as a maintenance therapy, prednisone as a given therapy for her COPD and her exacerbations. It's a high dose at 40. And her D10W fluids for rehydration. Now, on day 7, she finally told us, or we asked, or something along the lines, we found out that she used to live in Puerto Rico 37 years ago and used to walk barefoot. Now, I'll explain a little bit more on why her being barefoot and in Puerto Rico has something to do with the disease. Also, in addition to what we found out on that day, she received a duodenal biopsy. So they went into her small intestine, cut out a little piece, and the results were negative for villus atrophy. Now, villus atrophy, because one of the concerns, she has low oral intake. She might be of low nutrition at the time with symptoms of diarrhea, bowel issues. We might be thinking maybe she has celiac disease. So duodenal biopsy, good thing to look out for. In addition to the negative for the villus atrophy, which would be characteristic of celiac disease, we got intraepithelial lymphocytes, granulomatoma, and dysplasia, which are all signs of maybe an inflamed, chronic type of state within the bowels. And lastly, from the duodenal biopsy, we found what we were looking for. We found scattered elements of within duodenal cysts, crypts, not cysts. Now, this is very characteristic of strongyloidiasis. As I mentioned earlier, there's the hookworms, which are much more known about. Hookworms, what they do is they hook onto the intestine and they pretty much float in the lumen and do their damage from there. Strongyloids, on the other side, they integrate themselves within the epithelial cells of the small intestine and do their damage from between the cells. So it's almost like they're hidden and they're almost protected. So that's why they call them duodenal crypts. In the stool, in addition to what we found in the biopsy, we have ova and larvae, which are also characteristic of strongyloides as an infection. And the final diagnosis, strongyloidiasis with acute duodenitis. Here I have a picture to show the life cycle of strongyloids, and in an attempt to show you a bigger picture, I printed it at the far back of your presentation, and it came out in portrait mode as opposed to landscape mode, which is what I wanted, but I didn't want to waste too much paper. There are two phases of strongyloids. Similar to other intestinal parasites, there is the phase where the parasite is in the soil, out in the open, and the phase where it is being a parasite inside the human host. Now, the phase where it is in the soil, it is the rhabditiform. It's a non-infective, just simply free-living phase of the parasite. The filariform is the state in which it actually infects human hosts. And basically, the way it works is, if we begin with the rhabditiform parasite living in the soil, usually feces-infected soil, someone will come by just walking barefoot, and the parasite will dig into your skin, through the lymphatic system, will find its way to your lungs. Once it gets to the lungs and the alveoli, it will penetrate the alveoli, climb its little way up the bronchi into the trachea, be swallowed, and end up in the small intestine. Now,
that's a long path.
It is a long path. So from the point of infection to the point of symptoms, it's actually about a 30-day period. So it takes a while for you to get that infection going. Now, once it reaches the small intestine, we got the molting and the maturation, and eventually that maturation is what becomes the rhabditiform, which ends up in feces and in the soil. And once again, I apologize for you stopped eating.
Oh no, it's
And that would leave us at stage number 3 of the filiform life cycle. Stage 4 and stage 5 are for those patients that might be immunocompromised. Specifically, hyperinfection is when the larvae don't make it out of the body in the rhabditiform stage and just change into the filariform or infectious stage in the stool and reinfect the same person. So usually the filariform will mature into rhabditiform, end up in the stool, end up in the soil, and then someone else will come by and step, and the infection happens to another person. But with hyperinfection, it happens within the same person. So it's just an ongoing cycle. Now, if patients are severely immunocompromised, and these are usually patients that are mostly the ones on high-dose steroids and also patients that have human T lymphocytic virus 1, they actually experience a dissemination of the parasite which travels anywhere in their body. So the most prominent places are the CNS, the lungs, the liver, but it could be, it could go out to your skin. So one of the signs of strongyloidiasis is actually the parasites coming out of people's skin. And that is called larva currents. Now, as far as the epidemiology, worldwide, infectious parasites might have infected about a quarter of the world's population, but strongyloids have about a share of about 100 to 200 million people. They're most prevalent in tropical and humid areas, including the southeastern United States. It's most common in immigrants, travelers, and Vietnam veterans. No race or age prevalence, although children run barefoot and older people might be more immunocompromised. And immunocompromised at risk, steroids, and even HIV, any other type of condition. This is just for your info. It didn't print out in the PowerPoint, so just memorize this and then come back and look at it. Clinical signs, so gastrointestinal, cramping, diarrhea, constipation, weight loss, pulmonary infiltrates from the parasites coming up into your lungs makes people wheeze a little bit, maybe productive coughing, exacerbations, the dermatologic, itching, lesions, multiple organ failure, especially in dissemination, and obviously rapid decline. Now, also in the process of dissemination, these parasites might make it to the CNS, and we can get things such as meningitis, seizures, altered mental status. As far as diagnosing history of travel, migration, immune status, and we want to check different body parts for different types of signs of the bug. We're going to go ahead and test the stool, do a string test. If anybody doesn't know what a string test, they throw a pill down your throat with a string, pull it back up a few hours later, see what's on it. Do a dental aspiration, so they get a liquid sample from within the small intestine, and immunologic tests like IgG. Treatment. Ivermectin is the primary therapy, and I've listed your dosing for you. The way it works is that it will depolarize chloride channels within the muscle and nerve cells of the nematodes so that they're paralyzed, killing them. Side effects include these listed here, fever, etc. And one of the nice things about it is it doesn't cross the blood-brain barrier. It is, however, only effective in intestinal stages, so once it's in the gut, it might be a little more difficult to treat when it's floating around in your body. And there's no resistance reported thus far, which is usually an issue with infectious disease treatments. We're worried about resistance. Albendazole is the second line treatment that we would recommend. I've listed the dosing for you. Now, the way it works is it inhibits a protein on tubulin, inhibiting proper glucose uptake and the absorptive and secretory functions of the parasite. And that's also something that kills them. The great thing about albendazole is that it stays within the gut. So even though it has been, it'll limit some of those CNS effects some of the other medications could give you. But as a result, we have abdominal pain. Diarrhea is one of the big ones because once it kills the bugs, you got to let them out. And some of the clinical pearls, poor GI absorption, probably the most important one. And just a thought, it is category C, although this one stays in the gut, so it might not have as much of an effect on the babies. Albendazole would be, I would say, probably the last line treatment of the three, and that is because unlike albendazole, even though it has the same mechanism of action, it crosses the gut barrier much more easily, and it is teratogenic. shown to be so in rats. And I won't go into this one too much because it is the third line treatment. Now, all those three treatments, although humans and parasites share similar cell structures, these medications are very selective to the actual hemorrhoids, or the nematodes. Now, comparison between agents. This isn't a very common disease state, especially in the first world countries. So finding evidence that compares one medication to the other with a good sample size is pretty difficult to find. Regardless, I found a Cochrane system review with 7 selected randomized controlled trials. And what they found, which coincided with some of the trials that approved ivermectin, was that ivermectin was much more likely to cure the infection than albendazole. Also, ivermectin lists a dosing therapy for 1 or 2 days, but in reality they showed that there is no difference between 1 or 2 days of therapy. However, that evidence it's of low quality, so it doesn't hurt to do 2 days, especially with ivermectin, which has no resistance shown. And thiabendazole, which was the first medication that was used back, approved in the 1960s, was the medication for treatment of strongyloides, even with albendazole around. However, it has been discontinued because of the side effects. Ivermectin is a much better option. Supportive care. So in addition to treating the parasite, we want to make sure a patient is surviving and able to breathe. So one of the most important things, SABAs and mechanical ventilators if people have trouble breathing. IV fluids, as we can imagine, someone that has diarrhea can be dehydrated. Antihistamines, we want to avoid steroids because those are going to immunocompromise the patient. And antibiotic therapy if we end up needing it for dissemination, meningitis, etc. On day 9, our patient, we're catching up with them. We see that finally the patient has improved as far as their blood pressure. It's just under their particular goal of 150/60. However, we have actually she has diabetes, so it's 140/90. So she's above her goal, but at least she's getting a little better. Her white blood cell count's decreasing, and overall improvement. Signs improvement. Prednisone was discontinued, which was one of the important things that had to be done. As far as the physician, he recommended that we continue to monitor the immunoglobulins. The immunoglobulins provide a quick test of the infection status of the patient. Also, we have to monitor ova and larvae in the stool, monitor CBCs and TMPs, and chest x-rays to make sure that there is no progression of the disease in the lungs. And the patient was put on ivermectin at a dose of 200 micrograms per kilogram, which was 10.5 milligrams. Now, my professional opinion, well, I was happy to say that this patient received the proper treatment. Like I mentioned earlier, the correct choice of ivermectin was probably 2 days of therapy over 1. Because of concerns of possible reoccurrence of the infection in the future, they will be getting or they should have gotten about 2 days ago, the second dose of ivermectin to kind of make sure that everything's killed off, since this patient had been infected for so long. The supportive treatment and the therapy was on point, and the only thing I could say that was missed was questioning where the patient lived and making them kind of suffer for another 6 days. But it's not a common disease state, so otherwise I think they did great. And in summary, the patient was admitted, so we discussed that. We discussed what they showed up with. I explained a little bit about the disease.